Good evening, ladies and gentlemen. I'm Jerry Capel, the CEO of the Library Foundation. And there's a very important reason why I'm here tonight. Yes. I'm going to introduce to you one of our board members who has been really the driving force behind our Medicine in Our Backyard series. She's going to introduce someone who's also very important for our Medicine in Our Backyard series. This is something that we do for the Newport Beach Public Library. It's not for the foundation. It's for this terrific library that's down at the other end of the Civic Center. You know, we just got some facts and figures at our board meeting tonight. And last year, over 500,000 people walked through the doors of the library. We loan out more books than any other library in Orange County. We had almost 100,000 people attend programs. So, you know, this may be the community room, but that library is in fact the community center for Newport Beach and the surrounding communities. And the Library Foundation is just, we are excited and pleased to be able to support that sort of an institution that means so much to this community, to you, and to everyone else in Newport Beach and the surrounding areas. I've been with the foundation almost 5 years now. I was younger when I started. The lady I'm going to introduce to you has really been really a right-hand person for me in many aspects the last 5 years. Been a champion of the Library Foundation and a champion for this program. So please welcome Adrienne Weezer.
Thank you, Jerry, and welcome everybody. As he said, I'm Adrienne Windsor. I'm on the board of the foundation, and I'm really pleased to see you all here tonight. This is a joint program between the Newport Beach Library Foundation and UCI Health. And we have a very special person here tonight, Jan Shea. Would you stand, Jan? She is the daughter of Mike and Polly Smith. They have been the benefactors of Medicine in Our Backyard since its very beginning. So please, let's give some applause for that. Now, this program is one of many that is sponsored by the foundation. The foundation is a membership organization. How many of you are members? Well, I see some of you who didn't raise your hands. I hope we can rectify that. One of the things that we do every year, we have a summer solstice. It will be held on June 24th this year, and it's to acknowledge new members. The threshold membership in this foundation is only $50, and when you become a member, you get a copy of our bookmark, you get notice of the programs, the ones that are ticketed, that comes early. And if you come to the summer solstice, you'll have an opportunity to meet the board, to meet our major donors, to meet our staff, the library staff. And it's a time that we love to build community. So I urge you all to step up, become a member, and be a part of this. The foundation raised half the money for that magnificent Whitty Hall that's almost finished. And that was a gargantuan, I think, gift to this community. Once you enter that hall, you realize how absolutely magnificent it is. So please join. All right, now, if you haven't silenced your cell phones, please do that. Another business thing for this evening, we will have Q&A at the end of the presentation, so please save your questions until the end, after it's over. And We are videotaping this, so please refrain from your personal diagnosis when you ask your questions and try to keep them generic. How many of you have had knee replacements? How many of you need knee replacements? Okay. How many of you have had a cracked kneecap? I have. It's a pretty common thing, and so we're very lucky tonight to have two gentlemen with us to help us with these issues that we are encountering as we move along in our life path. So first of all, we have Dr. Navid Alem. He is a board-certified UCI Health anesthesiologist who has advanced training in pain management and anesthesia. He earned his medical degree at UCI School of Medicine and completed his residency in anesthesiology at the Keck School of Medicine at USC in Los Angeles. He also received training in an array of medical interventional and behavioral modalities to assist patients with acute and chronic pain syndromes. He continued additional training at USC in anesthesiology for complex neurosurgical cases. So if you're going under the anesthesia, this is the doctor that you want. Our second speaker tonight is Dr. Ryan DiGiovanni. He is a fellowship-trained UCI Health orthopedic surgeon who specializes in hip and knee arthroplasty. His clinical interests include the management and surgical treatment of knee and hip arthritis, including primary and revision arthroplasty procedures. Dr. Giovanni earned his medical degrees from the University of Arizona College of Medicine in Tucson, where he completed a residency in orthopedic surgery. He completed a fellowship in joint replacement at the Keck School of Medicine at USC. So please join me in welcoming our two speakers tonight. Thank you so much for being with us.
Well, thank you so much for having us on behalf of UCI. Both Dr. Giovanni and I were super excited at this. You know, at our clinic, we treat all sorts of pain, from spine pain to back pain, neck pain, shoulder pain. But when Megan told me the subject was knee pain, I got particularly excited and passionate because that's a pain that I've actually had myself. In 2008, I tore my ACL playing basketball, and then I thought I was home free until about 2 years ago. I tore my meniscus, so that's when I retired basketball. And I realized that I'm probably prone to having osteoarthritis myself with those prior surgeries, and I already have learned a lot of tricks myself on how to manage knee pain. And I'll go through some of these things, and really what I like to do is really talk to you about the non-surgical options, and then hopefully I'll seamlessly transition over to the surgical options, which Dr. DiGiovanni will go through. One of the things I really like about our clinic is, just like what you're going to be seeing today, we work side by side in clinic as well. So it's kind of a unique setup where the pain medicine group and the orthopedic group are literally neighbors, and it's not uncommon where he'll walk over to me, I'll walk over to him or one of his colleagues and say, hey, I got this condition or that condition, I need your help, or he'll say, can you do this injection for me? So it's kind of unique. Right away, I'll know if this is something we need to escalate and vice versa. So with that said, I do have one disclosure. I'm a consultant for a company that does nerve stimulation, which is actually going to be talked about in this talk as well, as we treat pain. And the reason I'm a consultant is because I've done hundreds of these, probably the most on the West Coast, so they asked me to teach other doctors about it. So knee pain is one of the most common causes of limited mobility, reduced independence, decreased quality of life. It affects all populations, active individuals, the aging population, post-injury and post-surgical patients. And with the right combination of treatments, most knee pain can improve without surgery. It's almost like fixing a car. You got to know what's broken before you fix it. And what helps patient X doesn't help patient Y, right? Everybody's different. So treatment works best when it matches the source of the pain. And it kind of goes beyond that in that you also have to tailor it to the patient. For example, one patient, an anti-inflammatory might be incredibly dangerous, and in another patient, an anti-inflammatory might be all they need. So I kind of break down the knee pain into various realms. One can be the actual joint, and that's where a lot of common conditions like arthritis and meniscus injuries can occur. It can be the soft tissue, so the tendons or the ligaments. It can be nerve-related pain. We in particular see a lot of nerve-related pain if you've had a prior knee replacement. A lot of patients describe burning pain around the knee because some of those nerves can be affected. And pain sensitization can occur as well through a variety of conditions. And, there's a lot of different conditions and names out there, but one of the things we talk about is acute pain versus chronic pain. And some people define acute pain as pain that's, less than 3 months, whereas chronic pain is more than 3 months. But I like to define acute pain when the pain is a symptom of something else, and chronic pain is when the pain is the pain itself, meaning there's not an underlying thing that's causing it, it's the chronic pain itself. So the most common causes of knee pain is really osteoarthritis. It's basically when the bone is touching bone, and that's when the cartilage wears down through, use over time. There's other conditions like patellofemoral pain, where you can have the patella basically cause pain in the top of our knee here. You can have meniscal injury, which is what I suffered. You can have ligament injury, which is also what I suffered. And we talked about post-surgical pain. Many patients have overlap, and it's not just one diagnosis. If I were to get an MRI in this room, including myself, most of us would have some element of meniscal degeneration. Most of us would have some element of arthritis. Not all of that needs to be operated on. Not all of that needs to have an intervention. But depending on what fails or what doesn't, we kind of rev up. And the way I like to look at it is there are some conditions which we'll talk about which are acute surgical emergencies. Those are rare. Most of the time it's not. And I like to treat my patients like my loved ones, where I take a hierarchical approach, where I say, let's try this. If this doesn't work, then we'll go one layer higher, one layer higher, one layer higher, as opposed to jumping out to the biggest weapon per se right away. So as I talked about, there are some conditions that are not to be sat on. And these are luckily rare conditions. Things like infection, right? So how do you know if you have an infection? If you have fever, chills, pain out of proportion, knee swelling, redness, you would know if you are having something above and beyond the normal. And that's an emergency. You would want to go to the ER or see Dr. DiGiovanni right away so that we could send the right labs, drain that, figure out if it needs to have surgery. Fractures, a locked knee, so you can't move your knee at all. These are not things you come see me for. These are the things you need to go right away to assess with an MRI and or more advanced treatments. Rapid swelling. If you have a history of cancer and something new is going on in your knee where you think that it might have spread there, or, pain out of proportion, you want to get it worked up, right? And sometimes these might require more urgent medical evaluation as opposed to what I do, which is mask the pain so that you could live your best life. And that's where I come in, right? We know it's osteoarthritis. It's not necessarily dangerous, but it's inhibiting you from doing what you want to do. And now that we have, the clearance that it's not anything scary, but it still, for a lack of a better term, sucks, what can we do to make it be more unsucky? So really what I talk about in pain medicine really revolves around is this concept of a multimodal approach. And I really give it the analogy of baking a cookie. I'm not much of a chef myself, but I know that different ingredients go into a cookie, right? It's not just chocolate chips. And so some people come and say, oh, I want opioids. And you go, okay, well, that's part of the puzzle for certain patients, maybe, but it's not what's going to make you live your best life. It's more like you need the flour, you need the sugar, you need the chocolate chips. And I don't bake, but anyone that bakes can give me maybe 4 or 5 other ingredients. Same thing that goes into pain medicine, right? There's an ingredients that go, but again, you might have an allergy to nuts. You might have a certain thing that you can't have because of your condition, but the cookie's going to taste better if you give the patient the right ingredients for their particular palate or their particular condition. So really for everybody, you want to talk about physical therapy, right? And whether you've seen physical therapies before you saw me or after you see me, we really do parallel process physical therapy, parallel process it. So a lot of times patients say, I can't do physical therapy because it's too painful. And that's where I'll come in to give you pain relief so that you can do physical therapy. And, Quadriceps strength is critical. Hip stabilizers, mobility and flexibility, gait and movement mechanics, activity modification, not really avoidance. We're not trying to avoid activities, we're trying to modify them. And movement itself is medicine, but targeted movement is even more powerful. Now, I don't think I talk about this, but weight loss is clutch, right? For every 1 pound of weight you lose, 4 pounds less pressure go on your knee. Right? For me, getting back to sports after an ACL injury, and I played pretty high level, was incredibly challenging. And I did all the physical therapy you can imagine. I went and did home exercises. I was relentless. I YouTubed exercises. I did everything. But it wasn't until I got down to a 10-pound lower weight where all of a sudden I had a lot less pressure on my knee and I was a lot more nimble. And it's very important to recognize that little modifications like that actually go a long way. So we talked about weight optimization, bracing. There's all sorts of braces. It's not for everybody. But for example, sometimes we'll get an x-ray and you have a lot of arthritis on the inside of your knee. So there's certain kinds of braces that specifically unload the inside of your knee. There's other soft braces for swelling, and they help you with this concept of proprioception so you know where you are. If you have patellofemoral pain syndrome, there's a particular kind of brace we put at the top of your knee. Footwear modifications, right? So, you have to have the right shoes with the right insoles. Activity pacing, balancing activity and rest. And, small changes can significantly reduce the stress on your joints, okay? And so we always talk about these simple interventions. And then medications. Now, this slide is a little dense and I don't want to go into it, but, we have this array of medications that we could do. For example, we have topicals, which is usually where I start. So FDA approved something like Voltaren, which I'm sure a lot of you have tried. You have the lidocaine patches. Now I can prescribe you from a physician's perspective what we call compounded creams, where I say I don't want just anti-inflammatory. I also want nerve agents like gabapentin and ketamine, or anti-inflammatories at higher than prescription doses or numbing doses. And I can basically make a compounding pharmacist make it tailored to your weight, tailored to what I want them to make. And the good thing about compounding creams is like oral gabapentin might cause systemic side effects, but topicals don't. If you have kidney disease, you can't take ibuprofen, but you can take it in topical form. Little things we could do like that. And then we talked about oral anti-inflammatories, which really help with pain, but they have some systemic side effects. So you really want to tailor it to your systemic conditions and make sure you're safe for it. Tylenol, believe it or not, very effective. And you want to optimize your dose, like 1,000 milligrams every 8 hours, unless you have certain conditions otherwise. And then we have an array of nerve medications, right? So if you have nerve-related pain, we can give you different medicines. So, antidepressants, neuropathic agents that we talk about. There's a whole array of them. And depending on what your presentation is, we can decide if your appropriate medicine is this or that. And then muscle relaxants. This new drug I'm sure a lot of you have heard about, suzetrigine or Journevax, which is indicated for acute pain. It's non-opioid, and it's almost like an antibiotic course. You take it for 2 weeks. It's a one-time thing. It works on a novel receptor, sodium channel, and it's a game changer when you just have surgery if you're trying to recover without having opioids or less opioid or whatever it is. And they found it to be just as effective as Norco. There's a medicine out there called low-dose naltrexone, which is not an opioid, but it makes your own body produce more opioid. So it's very effective for certain conditions. And then there's definitely a role for opioids, especially depending on the pathology you have, if you just have surgery or other sorts of conditions. And opioids come in short-acting and long-acting form, and they're not for everybody. We know that they have some side effects, but when given right, there are different ones, including partial agonists, which are much safer when you talk about this concept of respiratory depression and all the scary stuff you see on the news. They're a little less implicated in that. So medications help control pain, but they don't fix the underlying issue. And then this is really where, I don't want to say pain medicine shines, but this is where we really try to help patients in ways that other primary specialties might not do, and that's injection therapies, right? So a lot of times we start with a corticosteroid injection, which is very short-term, like immediate relief. Like if you're going to go to a Europe trip or a wedding and you just need to have 3 months of no pain, it's very effective. It's also helpful for diagnostic purpose, right? If you're not really sure if it's really knee pain or is it back pain, right? If you do a back shot and they don't get better, and you do a knee shot and they get better, but the MRI showed really bad knee and back arthritis, now Dr. DiGiovanni knows if he's supposed to do knee surgery or if the back surgeon's supposed to do back surgery. We have hyaluronic acid, which actually comes, does anyone know where hyaluronic acid comes from?
Oh, something funny like scallops or seafood.
Close. It comes from roosters. Yeah, basically it's this, I call it like a lubrication. It's like a gel, and it comes in different forms that can be one shot or a series of 3, and especially with mild or moderate osteoarthritis, it's very effective, although I'll try it for severe osteoarthritis as well. And basically it's less bone on bone because you have a gel layer, right? And so sometimes I'll try a steroid shot, sometimes I won't because you are not a good candidate for that. Or sometimes we'll try a gel or vice versa. We also have PRP, which is an emerging option, and that's when you splin your own blood, and then you take the growth factors and you give the patient back that layer, and it's very helpful for in a completely different way than steroids. Steroids are anti-inflammatory, so inflammation goes down. Platelet-rich plasma basically sends nutrients to the area of pain. And when you have an injection, a lot of patients tell me, well, I already had a steroid shot and it didn't work. I'm sometimes skeptical because a lot of times patients have shots that are done blindly, meaning the doctor just does it in clinic. But did they use ultrasound? Did they use x-ray? Did they use some sort of advanced modality to make sure you get the medicine in the right spot? I do x-ray guided and ultrasounded, and sometimes I'll think I'm in the right spot, and I'll say, oh, that's definitely in. And then I'll give contrast, and I'll see, wait, I'm not in. I need to go forward a little bit more. And then you see it's in the right spot. So sometimes it's frustrating when someone has had a shot and they think it doesn't work, but I'm not sure if they got it in the right spot. So remember, all these options are best alongside rehab, so you also improve function and can get your rehab going. So this is an example of an x-ray guided knee injection, and the mustache sign is what we say here, which is where you see that little black blob. It kind of looks like a mustache. And that's when you know you're actually in the joint capsule. And then you're like, okay, I'm going to give my gel or I'm going to give my steroid. But if I'm doing it blindly, I don't know where I am. So when pain persists, there are other, I don't want to say cutting edge, but other procedures that we do, okay? One of the things that I do very often, I think I did 4 of them today, is this genicular radiofrequency ablation procedure. So the knee has nerves that go to it, and we have talked about interventional options in the knee. But let's say you've already had a knee replacement, or let's say your arthritis is so significant that I can't even get in the knee because it's that bone on bone. It's literally bone on bone. Sometimes patients have tumor-related pain or all sorts of different stuff. I don't really care what the pathology is. In fact, you could technically even have an infection, although I wouldn't do it if you have an infection. But what we do is we go outside of your knee, and we have predictable anatomy of these nerves, and we put a little bit of numbing directly on those nerves. And invariably, you're going to say, wow, this is the best I've ever felt. You're going to feel no pain. It's almost like going to the dentist. But when you go to the dentist, you feel good for what? An hour or 2. But by the time you come home, you're not drooling anymore, right? And that's because the numbing wears off. So you might ask, what's the point of doing a procedure that's only going to help me for an hour? Well, it's basically a proof of concept. And if you get that dramatic response, which most patients do, then I bring you back at a later date, but I don't just put numbing. I put numbing, and then I put a little bit of a wire through the needle that has a heated tip. And then for 80 seconds, we heat those nerves. And these are just sensory nerves. They're not involved in mobility at all. And patients essentially dull out the pain. And 50 to 80%, depending on what study you read, of patients get upwards of 6 months of pain relief. And the good news is if the radiofrequency ablation works, I don't have to do those test blocks ever again. It's just one time where you do the trial run, and then 6 months, a year later, I just do the repeat ablation, and that basically gets you through non-operative options and or operative options. I have certain patients that are clear-cut knee replacement candidates, but they have significant heart disease or other sorts of comorbidities, and they're not necessarily as safe to undergo anesthesia, so we do this instead because there's no sedation needed. It's a local-only procedure. You're in clinic talking to me, and we're listening to music. Maybe something like Justin Bieber. I'm just kidding, we don't do that. Okay, so it really helps with the pain signals that are being transmitted when we do this. And here's a diagram of it, of the nerves I'm targeting. And then it's, as we talked about, very effective so that you can move better. So sometimes even a genicular radiofrequency ablation doesn't work. And so as you know, our body has nerves throughout the body. Every part of our body has a nerve. And since we're talking about knee pain, I'll talk about one of the nerves that goes to the knee, which is the saphenous nerve. It comes out from our spine and it comes down to our femoral nerve, and then it splits up and goes to innervate most of our knee. Now, when Dr. DiGiovanni does knee replacement, oftentimes he'll ask our anesthesiology colleagues before surgery to find that nerve with an ultrasound, and they will put a little wire, or I do it if I'm doing that assignment, and the wire is basically like an angel hair pasta that is hollow on the inside, and it dribbles numbing medicine for about 3 to 5 days so that you, on top of taking medicines and other sorts of stuff, can actually feel less pain continuously because you're dribbling numbing medicine towards that nerve. That's more of a procedure that you do right when you're having surgery, right? Because surgical pain, you need to numb out the pain. Well, that's not what I do in the outpatient realm. In the outpatient realm, what I could do is find that exact same nerve with ultrasound and or any other nerve, depending on where your pain is. Like for the shoulder, we don't target the saphenous, we target the suprascapular, or whatever pain you have. But what I do is I leave a little wire there, and then I glue that wire to your skin with a little bit of adhesive. And for 2 months, you wear a tiny little battery pack. It kind of looks like this for the knee. And basically, the concept is if I send pleasant, non-painful signals, it will basically drown out painful signals. And I don't know how many of you guys have had vaccines, but what happens if you get a vaccine? If you rub your arm, you feel the shot less, right? Because our brains and spinal cord are primitive. They have a limited bandwidth of information. And if you look at your spinal cord, you have what are called wider range neurons. And these neurons can wear hats for pain, or they can wear hats for touch. And if I send a pleasant signal, those hats start to wear the hat of not pain, but other signals. And by wearing this device for 2 months, you basically rewire your pain pathways so that you can get 6 months to a year of relief. And it's an incredibly safe procedure. None of these procedures I've given you are terribly dangerous, and I can talk to you about the risk of maybe if you're interested when we go through our Q&A, but they don't work for everybody. And that's where I really think it's important to understand that you have to have this baking a cookie. And to put it all together, movement and PT is a foundation. Lifestyle optimization, medications are supported, injections as needed, nerve-based treatments for selected patients, and no single treatment works best. It's combination therapy. And from there, I'll move on to my colleague, Dr. DiGiovanni from Orthopaedic, who will talk to you about surgical options.
That was excellent. Thank you. And thank you guys for having us here. Wonderful day and beautiful building. So I think to echo Dr. Alem, we work up the ladder. So in medicine, we think of things as risk and benefit. And so usually we try the things with the least amount of risk to try to get the most amount of benefit. And so when we start talking about surgery, these involve a little bit more risk. And so we like to try all those things first. I also do a little bit of education and consulting for a couple of device companies as well. I think the knee is fascinating. It's very complex. It moves in a lot of different directions. It has a lot of muscles, it has a lot of ligaments, it has a lot of tendons that surround it. And it makes it a very unique joint. Dr. Lim was talking about his ACL. We also have the PCL, the MCL, and the LCL are kind of the 4 main stabilizing ligaments of the knee. There's kind of 3 different joint surfaces that we think of in the knee. We think of the inside part, that's called the medial compartment. The outside part is called the lateral compartment. And then the other one is underneath the kneecap. So we call that the patellofemoral articulation. So I kind of think of the knee as 3 different compartments with important ligaments that kind of stabilize and help it move in multiple directions. So we say that the knee has 6 degrees of freedom. That means it can flex and extend, it can translate anterior, posterior, it can rotate, and then it can varus valgus as well. So it's not just a simple swing. Some people think of the knee as just moving front and back, but it does a lot more than that, and it's very complex. And so as a joint replacement surgeon, a lot of times I'm thinking about, what is a patient's normal knee anatomy, what is their normal, or like what they're used to. And I think everybody's a little bit different. And one of the things I'll talk about is some technology that we have that kind of helps assess patients' ligamentous status and what an individual knee would feel like. This is one of my favorite pictures. So this is an arthroscopic picture. So this is, going with a couple of small incisions, a camera, and a couple instruments that go through small incisions. But this is looking at cartilage and the meniscus, and you can see just these pristine, white, smooth structures. The meniscus I kind of think of as the shock absorber, and then the cartilage allows the two bone ends of the joint to guide smoothly. It has less friction than two pieces of ice rubbing against each other when you have full thickness and healthy cartilage intact. The unfortunate part, and why they're so white, is that they're mostly avascular, which means once they're damaged, they don't tend to heal in the same way that they were before. They get a lot of their nutrients from diffusion, and without that blood supply, it's hard to get them to heal. This is a cartoon demonstration of kind of what the meniscus looks like, and so there's one on the inside and one on the outside. And again, these are kind of vitally important structures. So one of the things that I get commonly asked in clinic is, can I have surgery that's the arthroscopic, like the picture that I showed, or do I need a knee replacement? And so a lot of that comes down to, is it just an isolated meniscus injury, and is that meniscus injury what's causing the symptoms and the problems? And so to mention what Dr. Alem said earlier, that if we got an MRI, a lot of times we'll find incidental findings, but they may not be the source or the pain generator. And so a lot of times with the meniscus, it's isolated to either the inside or the outside part of the knee, and it can cause what we call mechanical symptoms, such as locking, catching, or popping. Those are usually meniscus tears that would tend to do well with an arthroscopic procedure. Arthroscopic surgery in the setting of arthritis can actually aggravate the underlying arthritis. So if you have a meniscal tear with arthritis, then it's a more personalized discussion of what that MRI looks like and what the presenting symptoms are. Arthritis is loss of that cartilage. And like I said, once that cartilage is gone, it unfortunately doesn't regenerate at the current time in 2026. If we were to fast forward 5 or 10 years, maybe it's going to be different. And it's something that we're working very hard at our universities to try to be able to regenerate that cartilage. Unfortunately, we're not quite there yet. You'll hear about, stem cell injections and all these different injections that, may prevent you from having a knee replacement. But I think a lot of those claims are potentially unfounded currently, given the studies that we have available to us. Arthritis comes in many different forms. Kind of the most common is osteoarthritis, and that's just wear and tear over time. So as we age, we have an increased prevalence of osteoarthritis. There's also a genetic predisposition. So you can thank your parents for a lot of osteoarthritic conditions. Post-traumatic means you had some sort of injury that caused abnormal forces on the cartilage, and that led to arthritis down the line. Inflammatory arthritis is actually like our body's immune system attacking the underlying cartilage. And so that would be like rheumatoid arthritis, psoriatic arthritis, lupus, conditions like that can lead to arthritis as well. And then post-infectious. So if you have an infection in a joint, if it's not treated in a timely fashion, it can damage the healthy cartilage that's there. That arthritis, so once you have exposed bone ends, you don't have that smooth gliding surface. That can precipitate inflammatory mediators that causes pain, swelling. A swelling of the knee joint, we call that an effusion. So that's where you'll feel a bump on the outside of your knee, and it looks bigger than the other side. Can also lead to decreased motion. And the big thing that I care about as an orthopedic surgeon is decrease in functionality. Life is motion. We want to keep you active. We want to keep you moving. It helps the rest of your body stay healthy if you can maintain that activity level. You'll hear about osteophytes, and so these are abnormal bony growths, and it's the body's reaction to abnormal forces or arthritis. So if the MCL and the LCL, if you tension those ligaments and the osteophytes are doing that, you can have decreased force, so less abnormal force through the knee joint, and it's kind of the body's reaction in order to try to kind of stabilize a worn out joint. If we were to do no surgery and arthritis were to, progress over time, or severe arthritis, sometimes it can lead to an actual fusion of a joint as well. So when I see a patient in clinic, I really want to understand what your limitations are and what I can offer you to try to help make you better. What is our goal to get back to? Is that a reasonable goal that I can, something that I can offer can potentially provide with you? A lot of times we'll get an x-ray, so it can kind of guide our discussion, and we stage arthritis on this. It's called the Kellgren-Lawrence grading criteria, and it's a classification system that's 1 through 4, and it basically comes down to mild, moderate, or severe, and it kind of helps guide our discussion. And you can see here an x-ray of bone-on-bone arthritis, and once you're bone-on-bone, then you classify that as grade 4. There's kind of 2 ways that the knee can wear out. It can either become more bow-legged, or you can become more knock-kneed. It's more common to have the bow-legged deformity versus knock-kneed deformity, but as arthritis progresses, you lose that cartilage. You're going to start developing potentially one of these. The prevalence of arthritis, so it's estimated that 19% of patients or people over the age of 40 have knee arthritis, and that's projected to increase over time. Treatment options we already had discussed, but I will try all of these. I always feel that surgery is kind of an option of last resort, and so we usually will try non-steroidal anti-inflammatory medications, physical therapy, self-directed exercises programs, Tylenol as well. The surgical option that we have right now for advanced arthritis is joint replacement, also known as arthroplasty. And so what we do is we basically remove the area of arthritic bone plus a little bit of the underlying bone, and we resurface it with a metal implant that has a highly cross-linked polyethylene insert that goes in between it, with an option to use the same polyethylene insert underneath the patella if that is worn out as well. You'll notice the difference between these 2 pictures. There's also a partial knee replacement. So if you have arthritis that's just isolated to one of those compartments that we were talking about, one of the 3, you could potentially be a candidate for a partial knee replacement, which may have some advantages, and we'll talk about that a little bit more. You never need to have a joint replacement. I say, live with the knee that you have for as long as you can. Do the things to the highest level for as long as possible. Try to exhaust non-operative treatment measures as much as possible. But when that pain from your arthritis is limiting you from doing the things that you want to do, the bad days are outnumbering the good days, then it's time to consider a joint replacement. There are some risk factors for complications after surgery, and so a lot of my job is to decrease risks, and so tobacco use or any nicotine-containing products or vasoconstrictors that can lead to increased rates of infection or wound healing complications. So we try to work with you on, potentially tobacco cessation, any sort of active infection. And so this can be anywhere in your body. It's not necessarily just your knee. So, commonly if you have like a dental infection or you have dental work that needs to be done, a lot of times we'll try to optimize that. If you have any upcoming elective procedures, we try to have patients take care of those before, because we don't want to accidentally have some bacteria get into the bloodstream and then go into a joint replacement, which can have detrimental effects. We want to try to control our medical conditions as much as possible and go into surgery as optimized as possible. So one of those would be diabetes. The other thing that's of utmost importance is dedicating yourself to the rehab after surgery, which is almost just as important as the surgery itself. And a lot of that comes down to the care team that you have around you. At UCI, we offer a joint replacement class where everybody meets up. You go with our nurse navigators, and they talk to you about what the expectations are after surgery and what your care team around you can expect as well, and how we can best facilitate a good, healthy environment to rehab in. So with the knee replacement, a lot of it is physical therapy afterwards. And so really dedicating yourself to physical therapy. And I tell patients it's a tough first 3 months. You're working very hard for those 3 months to get the motion back, to give yourself the best chance for success. And that when is that best 3-month window? And I'd say that that 3 months is vitally important. So I wouldn't rush into a surgery. I'd wait to make sure that you have that 3 months to dedicate. So this is an x-ray of a partial knee replacement. Lindsey Vaughn famously, unfortunately had the crash, but she had a partial knee replacement and then came back to a high level of skiing. And so kind of temporal in the news and with the Olympics recently. But a partial knee replacement is indicated for patients that just have isolated either medial, lateral, or patellofemoral compartment arthritis. So a lot of times, if I ask a patient where their pain is, they'll be able to use one finger and they'll point right to the affected compartment. And they'll say, that is where my pain is. My pain is only there. And I use that as an important prognostic indicator of if a patient is potentially a candidate for a partial knee replacement. Because obviously we don't do anything to the other compartments. And so if those are pain generators, those would not be affected by a partial knee replacement. The thing that's nice about a partial knee replacement is that the ACL, which Dr. Alem had torn but had repaired, remains intact. With almost every knee replacement that's on the market, the ACL is resected. And so the knee never quite moves exactly like a native knee once you've had a knee replacement. If you have a partial knee replacement, it's more likely to move like a normal native knee than if you were to have a full knee replacement and you have to resect that ACL. When I think of a partial knee replacement, this is not a temporizing procedure. This is not to bias a few years before we do a full knee replacement. You should do the best operation first. And I think a well-done partial knee replacement can last just as long as a full knee replacement. I don't think of it as something to buy some time and, in order to get a full knee replacement. I want this to be the kind of final operation. There are cases where the arthritis can spread to the other compartments, necessitating another surgery from a partial knee replacement to a full knee replacement. But studies would show that a patient who has that operation, a partial to a full knee replacement, doesn't do as well as somebody who had a full knee replacement right off the bat. And so that's a very important discussion and determining factor in making sure that the correct operation is done the first time. So a total knee replacement will resurface both the medial lateral compartment and then, like I talked about, the patellofemoral compartment as well. Usually we're looking at the axis of the knee, so we look at from the center of the hip to the center of the ankle. When we develop arthritis in either way, the knee center can be outside where that mechanical axis is, leading to abnormal joint forces. And so, with a knee replacement, we can correct any sort of, bow-legged or knock-knee deformity. During a total knee replacement, one of the utmost important goals is balancing the ligaments appropriately. And so this is both with the knee extended and the knee flexed at 90 degrees. And then we also look at kind of like a mid-flexion as well. And so this is kind of the art of a knee replacement, is in order to balance the ligaments in both flexion and extension with the expectation of the implant that you're going to put in when it's all said and done. We have some new tools that help us with this soft tissue balance, and that's something that I'm very excited about. And so this is computer and robotic assisted surgery, which are more common, increasing in prevalence, and we have them offered at UCI as well. And so this tool basically allows us to map the bone and then assess the soft tissue and the ligament, how tight is the ligament in one side, in flexion and extension, before we have to make any resections of the bone. So we get a lot more information than if we were doing a traditional knee replacement before we start doing steps that are hard to go back from. So it gives us a lot more information earlier on in the operation, and then it allows us to plan the implant and the cuts, like I said, before we make them. And so we have a really good idea of how the knee is going to act when it's all said and done, and allows us to be more precise as well. These have been shown to have more accurate resections, to decrease outliers, which is beneficial. It also allows a sort of a customization and a personalization. It is going to assess your individual soft tissue tension for the knee replacement, and instead of just doing the same thing for everyone, you're able to make these kind of minor adjustments that hopefully give a better outcome. We also get a lot of real-time feedback, and we're able to make intraoperative adaptations to the surgery, and see how that affects those soft tissue gaps as well. It increases our precision, which is great, improves overall alignment and positioning of the components, potentially decreases soft tissue injury, may lead to less pain and quicker recovery, some studies have shown. So, I'm really excited about robotic knee replacement. The other thing is that we're a teaching institution, so part of my job is to train the next generation of surgeons. And I think that this is very exciting because I think a lot of our learners now are very visual. So this allows a screen to be in the operating room. They get to really see what the implant looks like and the adjustments that we make, how it affects the overall plan of the knee replacement. And so a lot of our learners, I think find this as a very valuable tool. It also helps, to keep everyone's safe during surgery, which is a big advantage as well. At UCI, we also focus on a rapid recovery program. So again, we go back to the education. Even before surgery, we try to answer a lot of the questions and things that may arise, and so that helps with recovery if you're educated going into it, and it's not just, oh my gosh, what did I get myself into when you're sent home from the hospital. We also really focus on hydration and nutrition before surgery. We use our anesthesia colleagues in multimodal pain control. We use those anesthetic blocks to help decrease the pain that comes with surgery. We try to be as soft tissue friendly as possible. We try to get patients up early and working with physical therapy. We try to have physical therapy come to your home if possible and really kind of guide that physical therapy pathway for you. And we want to get you back to doing the things that you want to do, whether that's some sort of sport, playing with grandkids, walking around every day to the grocery store without pain. That's what we're here to do and what makes my job so satisfying. So thank you guys for being a great audience.
I didn't see it up there. Oh,
A couple of microphones.
there it is. Okay. Oh, wait, yeah, we'll both have one. Sure, I'll go. All right, so we have questions. Here, we'll start over here.
Hi there. Thank you for the great talks. And Dr. DiGiovanni, you had a point about not recommending certain kind of insoles.
So lateral wedge insoles have not been proven to decrease the progression of arthritis. I would say that, yeah, so it's for patients with a varus knee deformity or a bow-legged deformity. If you wear an insole on the outside, the thinking that it would kind of shift the knee and decrease the amount of force that goes through it. I would say that, that particular type of insole is not recommended. With that being, that's not to say that, good supportive, comfortable shoes or insoles that provide cushion are not recommend. I would recommend those. I notice it in myself if I wear fancy dress shoes with wood bottoms, my joints hurt after a day. And so I do feel like good supportive shoes and good cushion are important.
Thank you for being here tonight and for both of you doctors, all the information you've provided. It's really interesting. My question is an MRI kind of a standard exam when you go in for knee pain, or is X-ray, only X-ray, kind of what happens?
It depends on the level of arthritis and the symptoms that a patient's presenting with. So I would say that we always would start off with an X-ray typically. If it's bone-on-bone arthritis, MRI is unlikely to change the management. So I will not routinely get an MRI on anybody unless there's certain red flag symptoms that I'm worried about something else going on. So I would say for arthritis itself, I don't typically order an MRI. But if the symptoms aren't adding up, or I'm worried about potentially a stress fracture or something that would be better seen on an MRI, then I'll order it, but not routinely.
Probably a question for Dr. Alem. How many times can you get a cortisone shot safely? Can you get one for a dozen or more times? And do you start? Does it start being that the pain returns more quickly than every 3 months?
Yeah, that's a great question. And I think Dr. DiGiovanni kind of hit it earlier where he said everything we do is in a risk-benefit analysis. Sometimes when you give steroids, outside of the actual knee, you have to really weigh the systemic side effects of steroids. We know that steroids can raise your blood pressure, they can raise your sugar, they can make your bone health be more prone to osteoporosis. They can suppress your own body's steroids, and that can be very dangerous. It can make you retain fluids. So if you have heart disease, you got to be cautious. So it's not taken lightly when we say, oh, we'll just give you steroids. And some studies say that it may promote cartilage wear and tear. But being inactive is not good for health. It's not good for your heart. It's not good for your quality of life, your mood, depression, all that. So most of the studies say that if you pick the right patient, steroids can be safe, but you don't want to overload them, as you mentioned. Now, there's some patients that aren't safe for it at all, but in my practice, we typically monitor how much steroid we give you and put it in the context of everything else. So if I give you a steroid shot in your knee and you get 30% relief, but you're still not where you want to be, and I'll try to not do that same shot for at least 3 to 6 months. But then I might do the gel, and that gives you an additional 30% relief. And then I might do the genicular radiofrequency ablation. And you might say, well, are you just rolling the wheel? Well, I'm giving you all the non-surgical options I have, which additively will get you feeling better, not one of them being magical per se. Depending on what your other options are and what works and what doesn't work and what's going on, we weigh it. But a lot of my patients are not just dealing with knee pain. They're dealing with hip pain. They're dealing with back pain. They're dealing with shoulder pain. And so you also have to be careful of which procedure you want to waste your steroid on, if that makes sense, right? Because you don't want to just give somebody a bunch of steroids every week. So yes, great question. But in the context of other options, it's oftentimes a risk benefit, and it ends up being the safest approach, as long as you're going to somebody who's not overzealous and watching your overall health. And that's why you come to someone who's a medical, a physician essentially, and kind of understands all the dynamics at hand.
Okay, thank you for a very interesting presentation for both non-surgical and surgical interventions. My question has to do with knee replacement or partial knee replacement surgery. How long does that last? Does it last forever? Does it last for N years? You have to do it again? Thank you.
Great question. So the polyethylene insert that is kind of sandwiched in between the two metal pieces, so the piece that we're using now came out in the early 2000s. So we have about 20 to 25 year follow-up on it right now. And about 85 to 90% are still doing well at 20 to 25 years. And so that's kind of what we're thinking, and we're following that along. But that was kind of the piece that was wearing out in the previous generations. And so that's kind of what we're looking at, but typically 20 to 25 years.
Thank you. I have one question about post-surgery. 3 years ago, I did have total knee replacement. Unfortunately, the adhesive that was used, I didn't find out about it until just recently. I'm allergic to it. And so that's why my knee really hasn't healed. And I'm hoping there's other options besides another surgery now to prevent the adhesive, or to prevent the replacement from loosening.
The adhesive that is onto the bone?
Yes.
Okay. Yeah, and so usually if the components are coming loose from the bone, then it typically would require a revision surgery to try to make them more secure.
No other options.
There's pain management options.
She's got a lot of that.
Yeah.
I have two questions. The first one is on the gel injections. What's the average, or is there any such thing? How long, once you start receiving the gel injections, how many years are you good for that? And then secondly, what's the status on the research that's being done on regrowth?
So the gel injections are more effective for mild or moderate osteoarthritis. When you have severe arthritis, it's less effective because as you can imagine, if it's already bone on bone, even if you put a protective barrier or something in between, you're going to have more contact. So I've had patients where I try the gel and they have zero relief. And it's not a wasted effort per se, but it is. It ends up not working. But again, as we talked about, you're going through the hierarchy, so you gave yourself a chance. In other patients, it ends up working very well. My understanding for coverage is 6 months for the gel. So if I do the gel for you today and it wears off at 6 months and you were getting really good relief, then I'll just repeat the gel. And I actually have quite a few patients that will set up an appointment and they'll come and I haven't seen them for a year and they'll say the gel wore off and I'll do the gel again and then I'll see them in a year. And that buys time depending on what you do with everything else we talked about, physical therapy, weight loss, activity modification, certain things that you can and certain things you can't control like genetics and just wear and tear. But again, in terms of the gel, there's that one shot and then there's those shots of 3. So you can either give it as 6 mLs one time or you can give it 2 mLs 3. And studies haven't really shown that one is superior to the other. And depending on the patient, sometimes I just give them one shot because it's easier and less infection risk to go into the knee one time. Other times I've found it to be effective to do 2 at a time because when you give one and the inside of the knee is no longer hurting but just the outside is, then I can really tailor the next shot to be more on the outside. And I've found it kind of nice to be able to then give the third where the majority of the pain is. And you give a shot, it doesn't necessarily spread evenly, if that makes sense. So you might have 3 shots, but within 3 weeks, and then 6 months later you get 3 more, or you might get 1 shot and 6 months later, or even more, get another shot.
I have a question. Here. So if you have a torn meniscus, do you have to have it repaired or can you get by without it being repaired if you have bone-on-bone arthritis and then torn meniscus?
So torn meniscus is usually secondary to bone-on-bone arthritis. So if you can think about it, that meniscus lives in the space between the 2 bones, and if it's bone-on-bone, it just doesn't have enough room to and so it ends up having to tear. I kind of think of it like this. And so those are patients that typically will not do well with a surgery that's just directed at the meniscus. And so I would say that usually that's when we're talking about the non-operative options.
Sometimes, though, very rarely, you can have what's called a bucket handle, and I got that one, and that's where your meniscus flips on itself. And then it's like you have to flip it back. But that's rare, and that's like a high velocity thing. But I found out very sadly I could not have surgery.
So Doctor, September is my date. And I've heard of something called a jiffy knee replacement. What's the difference between what they're doing now and this jiffy that they're talking to me about?
So a jiffy knee replacement is, so when you make the arthrotomy or you access the knee joint, so there's an option to go through the quadriceps tendon or to split the muscle, the vastus medialis, or to go underneath the vastus medialis. And so the jiffy knee replacement elects to kind of go through the vastus medialis and kind of push everything to the side in order for exposure. It's touted as having some early functional benefits potentially if you do that, but the jury's still out over the long-term functional benefit of it. So, but maybe some early functional.
Okay. Question over here. What is the difference between the movement before you have regular knee and after having a replacement?
So that's a great question. So the biggest predictor of post-operative range of motion is your preoperative range of motion. We always try to get patients to at least 120 degrees of flexion, if not more. And then probably even more than the flexion, which people want to focus on, is getting fully out straight. So that's probably the most important. But what we're shooting for is 0 to 120 degrees, if not more.
Can you explain how a Baker's cyst is related to a torn meniscus? And if a Baker's cyst has to be drained frequently, would that mean that a total knee replacement is needed?
Yeah, so Baker's cyst is commonly associated with Baker's cyst. So a tear in the meniscus allows fluid to get into the back of the knee and kind of expands the capsule in the posterior aspect. That can cause some compression on some of the, tendons and cause pain in the posterior aspect of the knee. So one option is to potentially, under ultrasound guidance, to have it drained and potentially have a cortisone injection, but a lot of times it can recur as well. When we do a knee replacement, we take out the meniscus. We usually drain any sort of Baker's cyst, and hopefully it can decrease the risk of that Baker's cyst coming back.
Okay, hello, thank you very much. I want to reinforce what you were saying about the need for physical therapy and the duration of exercise that can be painful for a long time, actually. I had a total knee replacement. I had good bones, but a soccer accident, and the physician said, wait till you're 70 because the technology is changing rapidly, and if you can tolerate it with a walking stick, wait till then. So I did, and had it at Rochester. We stayed for a week or two afterwards. How long? We stayed a month afterwards to go through the physical therapy there, and that was very, very helpful. And I don't remember, was I actually, I was walking around, sort of walking around. But when we got back home, for several months, I don't remember exactly how long, but it was weeks and weeks. Every night at about 2 a.m. or 3 a.m., I had an alarm clock. I would get up and walk half a mile back and forth in our house, rather slowly, but with a walking stick. And I did this religiously because I wanted to make sure that I would have as much flexure as possible in my knee. And that turned out to be successful. I didn't trust my knee for about a year. But one day I realized, hey, even though it feels unsteady, if I just stand and step, if I get up with it, I can do it. And so gradually I started treating the knee just like the other knee. It's been terrific ever since. So that's been about 18 years of...
Does anyone know how you know if you have a good physical therapist? You can't wait to go. No, I'm serious. Like, I've done my knee surgery. I didn't even talk to you about my pec surgery. I tore that in the gym. His colleague fixed me. But you go to different physical therapists in different groups, and sometimes they just want you to do exercises, and different physical therapists will actually be very hands-on and spend 30 minutes with you. I don't want to say massaging, but doing all the special stuff that's like hands-on. And the therapist that you're like, it's like, I can't wait to go, that's who you want to be going to. And a lot of my patients come and say, I hate physical therapy, they just hurt me. And right away I know what happened, because I had that experience too. They put you on a bike and said, I'll come back in 30 minutes, and it wasn't the same experience.
I have a question for you. It's a pain management question. And by the way, thank you so much for the slides and the talk. It's just wonderful, brilliant. The question I have is, let's say you've had a cortisone injection and you're coming up on maybe 4.5 months, and then you want to travel, and you're feeling okay, but you're going to be traveling for quite a while, maybe over a month. And is there something, like you talked about topical steroids, and is there something that you should take with you just in case it starts acting up? I'm going to be hiking, so it's...
Well, sometimes, first of all, you kind of know your response to certain things. So a lot of my patients temporally tell me, like, let's say like an epidural, they have sciatica, and the epidural lasts for 8 months. They'll tell me, hey, I want to get an epidural, long enough for it to last for me to go to Europe in June. So I'll tell them, hey, why don't we do it in May? And we know for sure you're going to have a good trip. But in answer to your question, it's tailored to you. So yeah, I mean, you look very healthy. Maybe some anti-inflammatory would be the right thing. I mean, obviously we don't know your medical history, but basically tailored to the patient, you could give somebody various things. Now, certain things are kind of non-pharmacologic, like you might want that brace when you're on your hike, versus pharmacologic, and depending on the nature of pain that you get, we sometimes give it before your hike or after your hike or for breakthrough. But you don't want to do the procedure, the steroid shot, for like a 0 to 3 pain, right, just because you know it's going to come on. But you want to really have like a 4 to 8. It's not preventative, right? So yeah, there's a lot of options, but really what you want to do is know how to time it if you can best. But I wouldn't say just get the shot because you're about to go, unless you know for a fact you're going to be gone long enough and it's probably going to wear off.
What about CBD cream? Have you had any experience with that?
Yeah, I mean, a lot of patients like CBD. The reality of it is I've found a lot of success with it as well. You just, it's not as regulated as some of the other stuff. So, I'm not telling you do this % with this or that. And when you go to a dispensary, you're not exactly sure what they're giving you per se, right? So, as a medical doctor, I'm very open to everything, and I can tell you that a lot of patients say they do better with it, and it helps them. I just can't tell you what you're getting when you go there, as opposed to when I prescribe you something or you're going to pick it up at CVS. I know that you're going to get what they tell you they're getting. But in terms of risks, creams, forms in particular, are very low risk from my experience.
Where do you get those creams?
Well, you can get them all over, and you can get them online. You could get them at dispensaries. You can, pharmacies. A lot of them that are kind of like compounding
the
stuff.
steroidal cream?
No, you said CBD.
Yeah, but as another option, if you're using.
So
a steroid
when I do
cream.
compounding creams, I don't put steroid in them typically. The creams are like my go-to for knee pain is ketamine, gabapentin, ketoprofen, and lidocaine, and then we put it like 10%, 5%, 5%, 5%. Basically, you can make any cream as long as you keep it less than 30%. So to put it into context, when you go over the counter and you get a cream, Voltaren is typically 1%. And even in the US, even the prescription typically doesn't get you above 1%. Although in like Canada, you can get up to 3%. But the cream is a 5% ketoprofen, so it's just stronger, right? And it's not for everybody, but it's pretty benign. I should tell you that compounding creams that the doctor prescribes, because they're made up, although they're very effective, most insurance companies don't approve. So then you're at the mercy of the compounding pharmacy, what they want to charge you. But usually they don't charge you all that much because they know if they charge you a lot, no one's going to be able to afford it.
Okay, thank you.
All right, we have one more question.
I think this is for Dr. DiGiovanni. You mentioned something about, just alluded to it quickly, that maybe in 5 or 10 years or something, we'll be able to grow cartilage. And I think what you're referring to maybe is that woman at Stanford that's making some headway, and she's got a biotech company down in San Diego.
Yeah.
Can I hold out? If I hold out for 5 years, what's the possibility that I can just get a great injection and get some cartilage back?
Yeah, I mean, we're going to eventually. I don't know when it's going to be, but I do know that, things are pretty rapidly evolving. It seems like, with AI, the information that we're gathering and research that, I feel like it's realistic to think that in 5 or 10 years, maybe we have made some headway. We've been working on it for a long time. I tell everyone, like, if you're a mouse or a rabbit, you're pretty safe at this point, but getting that transition to human cartilage is, it's been something that we've really been working on. So, I don't know. I think it's possible.
All right, let's thank Dr. Alem and Dr. DiGiovanni. Maybe you can come up and ask your question afterwards.
Is there an age limit at which either the surgical or the other options become kind of out-aged?
No. So no age limit. There's no age cutoff. We kind of look at everything. So we look at your health, we look at your activity level, and we don't discriminate based on age.
All right, thank you for coming tonight. Our next meeting is May 18th, and it will be on stroke. Okay, thank you so much.
Thank you.